Someone told you to breathe deeply. Someone else suggested eating a banana. You read somewhere that drinking beet juice could lower your numbers in minutes. Your neighbor swears by a cold glass of water. You have seen videos claiming that a specific pressure point on your wrist, held for 30 seconds, will bring your blood pressure down immediately. There are articles about dark chocolate, about lying on your left side, about exhaling slowly through pursed lips, about apple cider vinegar taken by the tablespoon. And underneath all of that conflicting information is a question that is entirely reasonable and that deserves a direct, honest answer. Can blood pressure actually be lowered in the moment, quickly, meaningfully, and safely through something you do yourself? Or is that the wrong question entirely? Is the thing that actually matters something different from what most people in this situation are focusing on? Today, I am going to answer both parts of that question. I am going to tell you what the evidence actually shows about the interventions people try when they want to bring blood pressure down quickly, which ones work, which ones do not, which ones are partially effective in ways that are often misunderstood, and which ones are potentially dangerous in specific situations. And then I am going to tell you what the research most consistently identifies as the most powerful modifier of blood pressure in adults over 60, not in the next 10 minutes, but in the next 10 weeks, because that is the timeline on which blood pressure is actually managed. And the obsession with immediate reduction often distracts from the longer-term interventions that produce the outcomes that actually matter for health. Before any of that, I need to establish something foundational, because the urgency behind the question, can I lower this right now, depends entirely on what the numbers actually mean in the moment. And most people checking their own blood pressure at home are not interpreting those numbers with the context they require. Blood pressure is not a static number. It fluctuates continuously throughout every day in response to dozens of variables that have nothing to do with cardiovascular disease. Standing up from a seated position raises it. Drinking coffee raises it. Having a conversation raises it. Feeling anxious about what the reading might show, a phenomenon called white coat effect that occurs in home measurement as reliably as in a clinic, raises it. Exercise raises it substantially. A full bladder raises it. Cold temperature raises it. Pain raises it. The simple act of holding your arm in an unsupported position while the cuff inflates raises it. A single blood pressure reading taken at any moment, without context and without the standardized conditions under which readings are clinically meaningful, tells you very little about your actual cardiovascular risk. A reading of 152/94 taken immediately after you walked up a flight of stairs, then sat down without resting, then placed the cuff on an unsupported arm while watching a news program that was making you anxious, is not the same cardiovascular situation as a reading of 152/94 taken after 5 minutes of quiet rest, in a consistently measured position, averaged across multiple readings on multiple days under consistent conditions. The clinical definition of hypertension, high blood pressure, requires elevated readings on multiple occasions, under standardized measurement conditions, over time. A single elevated reading at home is not a hypertensive crisis. It is a single data point that requires context before it has meaning. I am telling you this at the beginning because the impulse to immediately do something to bring a number down, before understanding what that number actually means in context, drives a significant proportion of the ineffective and sometimes harmful self-management behavior that surrounds blood pressure. The number produces anxiety, the anxiety raises blood pressure further, the person takes an intervention they believe will lower it quickly. They measure again in 5 minutes, still anxious, and the number is the same or higher, the anxiety escalates, and the cycle continues, generating genuine distress around a measurement that may have reflected nothing more than the fact that they forgot to sit quietly before measuring. Establish proper measurement technique before anything else. Sit quietly for 5 minutes before measuring. Feet flat on the floor, back supported, arm at heart level and supported by a surface, not held up by the other hand. Do not talk during the measurement. Do not cross your legs. Do not measure within 30 minutes of caffeine, exercise, or a large meal. Take 2 readings separated by 1 minute and average them. Do this at the same time of day consistently. This is not bureaucratic precision. It is the difference between information and noise. Now, what does and does not work? Let us start with what does not work. Or more precisely, what does not work in the way people believe it does. The first is breathing exercises as an immediate fix. Slow, controlled breathing, specifically techniques that extend the exhalation phase, such as breathing in for 4 counts and out for 6 or 8 counts, does produce a real and measurable reduction in blood pressure during the period in which it is practiced. This is not a myth. The mechanism is real. Slow breathing at frequencies below 10 breaths per minute activates the parasympathetic nervous system, the rest and digest branch of the autonomic nervous system, which reduces heart rate, reduces sympathetic vascular tone, and produces a decrease in blood pressure that is measurable on a cuff during or immediately after the breathing practice. The problem is the word immediately. The blood pressure reduction from slow breathing lasts for the duration of the practice and a brief window afterward, typically returning toward baseline within minutes of stopping. If you measure your blood pressure, see an elevated reading, sit quietly and breathe slowly for 5 minutes, and then measure again, you will very likely see a lower number. But a meaningful portion of that lower number reflects two things that have nothing to do with any lasting cardiovascular change. The 5 minutes of quiet rest that standardized measurement protocol requires anyway, and the reduction in acute anxiety that breathing practice produces. If you had simply sat quietly for 5 minutes without the specific breathing technique, your reading would likely have been lower too. This does not mean slow breathing has no value in blood pressure management. Device-guided slow breathing, specifically, has been studied in randomized controlled trials for its effect on resting blood pressure, and the results are meaningful. A 2016 study published in the Journal of Human Hypertension found that daily device-guided slow breathing practice over 8 weeks produced a statistically significant reduction in resting systolic blood pressure compared to control, with effects averaging around 5 to 10 millimeters of mercury in patients with established hypertension. That is clinically relevant, comparable to the effect of some antihypertensive medications, but it requires daily practice over weeks, not 5 minutes before a measurement. The distinction between a technique that modulates blood pressure acutely during practice versus one that produces lasting cardiovascular change through sustained neurological adaptation is crucial, and conflating the two leads to the incorrect belief that breathing is a tool for the moment of an elevated reading rather than a habit for long-term management. The second ineffective immediate intervention is the pressure point claim. There is a category of content, extremely common on social media and increasingly common on YouTube, describing specific anatomical points on the wrist, the neck, the hand, or the foot that, when pressed or massaged for a defined period, purportedly lower blood pressure substantially and immediately. The evidence for this is not there in any form that meets the standards of clinical medicine. There is a legitimate field of research examining acupressure and acupuncture for blood pressure management, and some of that research, particularly on sustained acupuncture practice over multiple sessions, shows modest effects on resting blood pressure through mechanisms involving autonomic nervous system modulation. A 2015 systematic review in the Journal of Human Hypertension found that acupuncture as a sustained therapy produced modest blood pressure reductions in some studies, with significant methodological heterogeneity across the literature, making definitive conclusions difficult. None of that research supports the claim that pressing a specific point for 30 seconds produces an immediate, meaningful reduction in blood pressure in a person experiencing an acute elevation. The biological mechanism for that specific claim does not exist in the peer-reviewed literature. The videos demonstrating dramatic drops in blood pressure following wrist pressure points are not controlled observations. They are before and after measurements that do not account for the multiple variables that cause blood pressure to fluctuate naturally between measurements taken minutes apart. If a technique appears to lower your blood pressure by 15 points in 2 minutes, the most likely explanation is that your blood pressure was already on its way down from the peak of an anxiety response, and it would have come down regardless of whether you pressed a pressure point or simply sat quietly in a chair. The third ineffective immediate intervention, and potentially the most dangerous, is the practice of taking an extra dose of antihypertensive medication in response to an elevated home reading. This is common, it is intuitive, it feels like the logical thing to do. The number is high, the medication is supposed to lower the number, therefore more medication will lower it faster. This reasoning is wrong, and acting on it can produce outcomes that are significantly more dangerous than the elevated reading that prompted it. Antihypertensive medications, ACE inhibitors, ARBs, calcium channel blockers, beta blockers, diuretics, are designed to produce a sustained, consistent, predictable reduction in blood pressure over time through mechanisms that operate over hours to days, not minutes. Taking an additional dose of a long-acting antihypertensive in response to an acute reading does not produce immediate pressure reduction in a way that is safe or predictable. What it produces is a cumulative medication effect that arrives hours later, often during sleep, and may lower blood pressure to a degree that causes its own set of serious problems. Symptomatic hypotension, blood pressure that drops too low, in older adults is associated with lightheadedness, falls, syncope, and in patients with coronary artery disease, myocardial ischemia from insufficient coronary perfusion pressure. Falls in adults over 60 with drug-induced hypotension are a significant cause of hip fractures, head injuries, and hospital admissions. An elderly person who takes an extra antihypertensive tablet in the evening because their home reading was elevated, then stands up in the night to use the bathroom, is at genuine risk of a fall that is far more immediately dangerous than the blood pressure reading that initiated the sequence. If you are taking prescription antihypertensive medication, do not self-adjust your dose in response to home readings without explicit guidance from your prescribing physician for exactly that situation. If your readings are consistently elevated despite medication compliance, that is a conversation to have with your physician, not a problem to address with dose self-escalation. The fourth category of ineffective immediate intervention is the range of home remedies: beet juice, hibiscus tea, garlic extract, dark chocolate, apple cider vinegar, consumed in response to an elevated reading with the expectation of a meaningful reduction within minutes. Several of these substances have genuine evidence behind them for blood pressure management, but the evidence, again, is for sustained use over time, not for acute ingestion in response to a single reading. Beet juice, specifically the dietary nitrate content of beetroot, has been studied for its effect on blood pressure, and the mechanism is real. Nitric oxide causes vasodilation, relaxation of the smooth muscle and blood vessel walls, which reduces peripheral vascular resistance and lowers blood pressure. A 2013 study published in Hypertension found that a single dose of beet juice produced a statistically significant reduction in blood pressure over 24 hours, with the effect peaking at 3 to 6 hours after consumption and returning toward baseline by 24 hours. The average reduction in that study was approximately 5 millimeters of mercury systolic. That is a real effect. It is not, however, an immediate effect, and 5 millimeters of mercury from a single dose is a modest change relative to the magnitude of blood pressure elevations that prompt people to reach for a glass of beet juice. As a component of a sustained dietary strategy, regular consumption of nitrate-rich vegetables including beets, leafy greens, and celery as part of an overall dietary pattern, the cumulative effect on resting blood pressure is more meaningful than any single dose. But as an immediate intervention for an acutely elevated reading, the timeline of effect does not match the expectation. Hibiscus tea has similar characteristics. Multiple randomized controlled trials have found that regular consumption of hibiscus tea, 2 to 3 cups daily over 4 to 6 weeks, produces reductions in systolic blood pressure averaging 5 to 7 millimeters of mercury compared to placebo, with the effect attributed to its high anthocyanin and organic acid content, producing both antioxidant and ACE-inhibiting effects. A 2010 study published in the Journal of Nutrition found that 3 cups of hibiscus tea daily for 6 weeks produced a meaningful reduction in systolic blood pressure in adults with prehypertension and mild hypertension. Again, real effect, sustained use, weeks not minutes. Dark chocolate, specifically high cacao content chocolate with minimal added sugar, contains flavonols that, over sustained consumption periods, produce modest improvements in endothelial function and modest reductions in blood pressure through nitric oxide-mediated mechanisms. A 2012 Cochrane review of 18 trials found that flavanol-rich cocoa products produce small but statistically significant reductions in blood pressure, averaging approximately 2 to 3 millimeters of mercury systolic, with the effect consistent across studies and occurring over supplementation periods of 2 to 8 weeks. 2 to 3 millimeters of mercury is a real cardiovascular benefit over a population, even if it feels modest for any individual. It is not a treatment for an acute elevated reading. None of this makes these substances ineffective. It makes them long-term dietary strategy components, not emergency interventions. The correct framing for all of them is, if I include these consistently in my diet over weeks and months, they contribute meaningfully to a lower resting blood pressure and to the overall cardiovascular environment I am trying to maintain. Not, if I consume this right now, my number will come down before I measure again. Now let us talk about what does work, genuinely, meaningfully, and with effect sizes that dwarf almost anything on the list above. Sit quietly. 5 minutes. Feet flat. Arms supported at heart level. No talking, no phone, no television. Nothing requiring cognitive engagement. Just 5 minutes of genuine quiet rest before the cuff inflates. In clinical studies examining the effect of pre-measurement rest on blood pressure readings, the average reduction in systolic blood pressure from 5 minutes of standardized quiet rest compared to immediate measurement after activity is 10 to 15 millimeters of mercury. In some individuals, particularly those with high sympathetic nervous system tone and anxiety around measurement, the effect is larger. The pre-measurement rest effect is not a trick or a confound to be eliminated. It is the legitimate baseline that blood pressure measurement is supposed to capture. The 5-minute rest is part of the measurement protocol precisely because blood pressure fluctuates around activity and emotional state, and the resting value is the clinically relevant one. If you have been measuring your blood pressure immediately after activity, without rest, while anxious about the result, without supporting your arm, while watching something stimulating, the number you have been getting is not an accurate reflection of your cardiovascular status. Correcting the measurement technique may reveal that the number you have been alarmed by does not accurately reflect your resting pressure at all. The second thing that works, genuinely in the moment and through a real physiological mechanism, is isometric hand grip exercise. This one is almost completely unknown outside of specific research circles, and I want to spend real time on it because the evidence is both surprising and robust. The specific adaptation relevant to blood pressure involves changes in the function of the arterial baroreceptors, the pressure sensors in the aorta and carotid arteries that regulate sympathetic nervous system output and thereby influence blood pressure. Sustained, regular isometric hand grip exercise, squeezing a hand grip device or a tennis ball at approximately 30% of maximal grip strength for 2 minutes, alternating hands for a total of 8 to 12 minutes, 3 to 4 times per week, has been studied in multiple randomized controlled trials for its effect on resting blood pressure. The results are striking in their consistency. A 2013 meta-analysis published in the Journal of Hypertension, analyzing 11 randomized controlled trials of isometric hand grip training, found that this practice produced a mean reduction in resting systolic blood pressure of approximately 10 millimeters of mercury and diastolic blood pressure of approximately 7 millimeters of mercury compared to control conditions. 10 millimeters of mercury systolic. That is a clinically meaningful reduction, equivalent to or exceeding the effect of many first-line antihypertensive medications in mild to moderate hypertension. A subsequent 2016 systematic review in the British Journal of Sports Medicine confirmed these findings across a broader evidence base, identifying isometric exercise as the modality with the strongest evidence for blood pressure reduction among all exercise types studied, including aerobic exercise and dynamic resistance training. The effect was consistent across age groups, including older adults specifically. The mechanism involves adaptive downward resetting of the arterial baroreflex, a neurological recalibration of the set point around which sympathetic nervous system activity regulates blood pressure, combined with improvements in arterial compliance and endothelial function that develop with sustained regular practice. This is not an acute reduction from a single session. It is the product of regular practice over 4 to 8 weeks. But once established, the reduction persists as long as the practice continues. A hand grip device costs less than $10. The practice takes 8 minutes per session. The evidence behind it is stronger than most people would expect from something this simple and this accessible. If you have hypertension and have not been told about isometric hand grip exercise by your physician, you now know something that the research has been showing for over a decade. The practical translation of sodium reduction is primarily about processed food, not the salt shaker. Approximately 70% of sodium intake in Western diets comes from processed and restaurant food, not from sodium added during cooking or at the table. Reducing processed food consumption, deli meats, canned soups, packaged snacks, restaurant meals, fast food, produces a far greater reduction in sodium intake than removing the salt shaker from the table. The effect of sodium reduction on blood pressure is not uniform across all individuals. There is a spectrum of sodium sensitivity, and some people's blood pressure responds more dramatically to sodium changes than others. But among adults over 60, the prevalence of salt sensitivity is significantly higher than in younger populations, partly because kidney function declines with age and the kidney's capacity to excrete a sodium load efficiently decreases, and partly because the renin-angiotensin-aldosterone system, the hormonal axis that regulates sodium balance and blood pressure, becomes less responsive to the normal regulatory signals with aging. A 2020 study published in the New England Journal of Medicine, the DASH sodium trial follow-up analysis, found that in older adults specifically, sodium reduction from high to low intake produced systolic blood pressure reductions averaging approximately 8 to 11 millimeters of mercury. In individuals who were already hypertensive, the effect was larger still, averaging 12 to 15 millimeters of mercury in some subgroups. The practical translation of sodium reduction is primarily about processed food, not the salt shaker. Approximately 70% of sodium intake in Western diets comes from processed and restaurant food, not from sodium added during cooking or at the table. Reducing processed food consumption, deli meats, canned soups, packaged snacks, restaurant meals, fast food, produces a far greater reduction in sodium intake than removing the salt shaker from the table. The strategies I described in detail in the kidney health context apply equally here. Reading ingredient labels for sodium content, replacing processed food with whole food across as many meals as possible, cooking from ingredients rather than from packages. The effect of sustained sodium reduction on blood pressure accumulates over weeks of consistent change. It is not immediate, but it is one of the most powerful and most evidence-supported strategies for meaningful blood pressure reduction available to anyone who is currently consuming a high-sodium processed food diet, which describes the majority of adults over 60 in Western countries. Regular moderate-intensity aerobic exercise, the equivalent of brisk walking for 30 minutes, 5 days per week, produces reductions in resting systolic blood pressure of approximately 5 to 8 millimeters of mercury and diastolic blood pressure of approximately 3 to 5 millimeters of mercury in adults with hypertension, with the effect appearing within 4 to 8 weeks of beginning a regular program and persisting as long as the activity continues. The cardiovascular adaptations of regular aerobic exercise collectively produce a sustained downward shift in the set point around which blood pressure is regulated, not through an acute effect of any single session, but through the neurological and vascular remodeling that develops with sustained regular practice. Combined with sodium reduction and isometric hand grip training, regular aerobic exercise produces a combined non-pharmacological blood pressure reduction that in individuals with stage 1 hypertension, systolic between 130 and 150, can be sufficient to bring pressure into a range where pharmacological treatment is either unnecessary or requires a lower dose, with proportionally fewer side effects. I want to specifically address 2 situations in which the question of immediate blood pressure reduction is genuinely urgent, not as a matter of an alarming home reading, but as a medical emergency. Because distinguishing between the two is essential, and I do not want to leave this conversation without that clarity. That evidence includes severe headache that is different from any previous headache, particularly if it is sudden in onset and worst at the back of the head. Visual disturbance, blurring, double vision, loss of vision in part of the visual field, chest pain or pressure, shortness of breath at rest, confusion, altered consciousness, or sudden difficulty speaking or understanding speech, numbness or weakness on one side of the body. These are not symptoms to manage at home with breathing exercises or beet juice. These are symptoms that require immediate emergency medical evaluation. Call emergency services. A hypertensive urgency is a situation in which blood pressure is severely elevated, above 180 over 120, without evidence of acute organ damage. The individual feels generally unwell, but does not have the neurological, visual, or cardiac symptoms described above. This situation also requires prompt medical evaluation, same-day contact with a physician or urgent care visit, but it does not require calling emergency services unless symptoms develop. A single elevated home reading in an otherwise asymptomatic individual, even a substantially elevated reading, is almost never a hypertensive emergency. It is a reading that requires context, proper measurement conditions, and physician communication, not panic and not self-treatment. If you have a home blood pressure monitor, which I encourage, because home monitoring over time gives a far more accurate picture of your true resting blood pressure than occasional clinic measurements, the appropriate response to a single elevated reading is to sit quietly, measure again in 5 minutes with proper technique, and if the reading remains substantially elevated without any of the symptoms described above, contact your physician for guidance, not to search for immediate interventions, not to take an extra medication dose, not to press a pressure point. The question embedded in today's title, "Can blood pressure be lowered instantly?" deserves a direct answer. In the sense of producing a meaningful, lasting reduction in true resting blood pressure through a single immediate action? No. That is not how blood pressure physiology works, and it is not what the evidence supports. Meaningful, durable changes in any of those factors require sustained behavioral change over weeks, not a single intervention in a moment of alarm. In the sense of producing a lower number on the next reading, several things work, but most of them work primarily by correcting the measurement conditions that artificially elevated the previous reading, or by reducing the acute sympathetic activation of anxiety, or by eliminating the artifacts of improper technique. The lower number reflects a more accurate measurement, not a cardiovascular intervention. In the sense of what you can start today that will produce a meaningfully lower true resting blood pressure within 4 to 8 weeks. Regular aerobic exercise, consistent sodium reduction through processed food replacement, and daily isometric hand grip practice represent the 3 best evidenced, most practically accessible, and most consistently effective non-pharmacological blood pressure management strategies available to adults over 60. None of them is dramatic. None of them produces the satisfying immediacy that a quick fix promises. All of them produce real, measurable, clinically meaningful results in the time frame that blood pressure management actually operates within. That is the honest answer. And the honest answer is more useful to your health than any version of the quick fix would be. If this gave you a clearer picture of what actually works and what does not, and more importantly, why, hit the like button right now. It tells this platform that honest, evidence-grounded cardiovascular health information for adults over 60 deserves to reach everyone who is searching for answers to this question. Subscribe and turn on the notification bell. Every week there is one video here that takes the time to explain the mechanism, not just the recommendation, because understanding why is what converts a piece of information into a lasting change in behavior. Leave me a comment answering this. When you measure your blood pressure at home, do you sit quietly for 5 minutes before measuring, or do you measure immediately after whatever you are doing? That single piece of measurement practice may be changing the numbers you are seeing more than you realize. Write your answer below. I read every comment and respond when I can.